Can everybody see that?
We can, thank you, Amy.
Brilliant. Do you want me to start?
Yes, I was just going to welcome everyone. So thank you everyone for coming along today. It's great to see so many of you here. Really pleased to have with us Amy Cheevers and Sharon Inslee, who are going to be talking about Parkinson's, and then also Laura, who is going to be introducing the Carers First service and a bit more information on that service and how to refer. Without further ado, I'll hand over, Amy, to you.
Brilliant, thank you. Thanks for the introduction. Yes, I'm Amy Cheevers, and I've got with me Sharon Inslee. It's not... A few aims of the sessions are to increase your knowledge and understanding of Parkinson's and identify the main medications used in the treatment of Parkinson's, and including some of their side effects and some of the associated challenges as well. And we've just got a couple of slides as well going over physiotherapy and in helping manage people with Parkinson's. Just briefly about us as Parkinson's team, we are a county-wide team. There's myself, Band 7 nurse specialist and the clinical team lead, and we have Deborah Whitfield, who's the Band 7 physio within our team, who's the operational lead. We have got 4 Band 6 nurses that cover county-wide. One of our nurses has just left, so the Lincoln and Gainsborough area is sort of being covered by everybody at the moment until we can sort some staffing out. And then we have David Smith and Tracy Watt, who are the Parkinson's nurses in the Acute Trust, and we link in with them on a regular basis for those who had been admitted to hospital. We've got our contact details there that take you to our admin team, and we've got our own Parkinson's email address that you're more than welcome to email. They're checked throughout the day. If you've got any questions or anything, sort of as we're going through, I'm more than happy for you to pop your hand up, put it in the chat. Sharon's keeping an eye out on that, as I can't see the sharing my screen. Firstly, I'd like to start off the session with just a little slide on the essay on the shaking palsy. It's been 200 years since Dr. James Parkinson wrote his essay on the shaking palsy, and this was the first clear description of the main features of Parkinson's. We now know that some of his statements are untrue, where he's written the senses and intellect being uninjured. We now know that those people with Parkinson's, 18 to 90% of those will actually lose their sense of smell. Sense of smell is now a preclinical indicator in the diagnosis of Parkinson's, and this includes constipation, slowness of movement, low mood, and REM sleep disorder. Also, where he's documented about the senses being uninjured, we'll now know that this is also false, with 50 to 80% of those with a Parkinson's diagnosis experiencing some form of mild cognitive impairment through to a full dementia diagnosis. So what actually is Parkinson's? Well, Parkinson's is a progressive neurological condition caused by the degeneration of dopamine-producing neurons in the substantia nigra. Now, I know it's only a Tuesday afternoon, but that's a bit much for me to swallow at times. So it's put in a bit of simpler terms. The neurons in the brain that produce dopamine are actually dying, and at time of diagnosis, these dopamine neurons, a person has lost 60 to 80%. So dopamine in itself means that people have difficulty controlling movements, and it also contributes to other cognitive processes like motivation, mood, decision making, and visual perception. So by the time a person has gone to the GP with some issues, it's normally what we term the motor functions. I'll come on to them in a little while. Problems with their mobility, they've maybe noted a gait or shuffling problem, or developed a tremor. 70% of those with a diagnosis of Parkinson's will have a tremor. It is the fastest growing neurological condition, and in the UK, every hour, 2 more people are diagnosed with Parkinson's. At current, there's no treatment to stop the progression or to slow the progression or even to cure Parkinson's. To make it a bit more difficult, Parkinson's is really difficult to actually diagnose. There's not one single test to tell somebody you have got Parkinson's. So the GP, as per our NICE guidelines, should refer a person who they think may have some sort of underlying issue to a consultant neurologist or geriatrician with a specific interest in Parkinson's, untreated. The consultant does an examination and looks at the preclinical markers that I spoke about previously, and also how that person is presenting to them at the time. The consultant might choose to use a DAT scan, a dopamine transporter scan, which is what's highlighted on your screen at the moment. Now, this tells us if there's a lack of dopamine uptake in that area of the brain. As you can see, there's the healthy control, mild Parkinson's, moderate Parkinson's, and then severe Parkinson's. This in itself is good to inform us whether there is a lack of uptake of dopamine, and it probably suggests that that person has some Parkinsonism features, but it doesn't differentiate between idiopathic Parkinson's and some of the atypical Parkinsonisms, which is what I'll come on to shortly. There are 4 stages of Parkinson's as per our NICE guidelines: diagnosis, maintenance, complex, and palliative. Parkinson's is very individual. How one person experiences Parkinson's will be very different to somebody else. I haven't got one person on the caseload that is on the same medication regime, and we need to remember that we have to treat the stage of the condition, not the age of the person. So we have some people on our caseload who are in their 90s who are very much in that early diagnosis maintenance stage. I've got a lady over in Lincoln who is in her early 40s that has just been diagnosed, and she is very much in the complex stages of Parkinson's already. We accept people on our caseload from diagnosis right the way down to the palliative stages. We can discuss advanced care planning, respect discussions, and inform the wider MDT as well when we need to. Parkinson's can be seen as a condition of 2 halves. You have the motor symptoms and what we term the non-motor symptoms. So to be diagnosed with Parkinson's, they have to meet the Parkinson's UK Brain Bank criteria, and the person has to have at least 2 of the 3 motor symptoms which are set out on this slide here: the bradykinesia, which is the slowness of movement, tremor, and rigidity. Normally you find when somebody's been diagnosed and we go out and see them, somebody often says that their non-motor symptoms are more problematic rather than the motor symptoms. The non-motor symptoms can range from fatigue, low blood pressure, bladder and bowel issues, anxiety, depression, pain. They can have problems with the eyes, hallucinations, and this list is not exhaustive. It's we do a non-motor symptom questionnaire at a time of diagnosis when on our first initial assessment, and then we keep an eye on these non-motor symptoms as that person progresses through their journey of Parkinson's. So with the Parkinsonisms, this is a term that refers to a collective group of conditions. As well as looking after those with idiopathic Parkinson's, we support those with the atypical Parkinson's diagnosis: multisystem atrophy, progressive supranuclear palsy, and corticobasal degeneration. This cohort of patients, the MSA, PSP, and CBD, are a very difficult cohort of patients to help support and manage. Less than 20% will have a relief from medications used in the idiopathic Parkinson's patients. With PSP, people tend to have early falls and falling backwards. They have visual issues because they don't have normal eye saccades, so they have issues with looking up and down. They can have a change in their behaviour quite soon on in the diagnosis, which is often picked up by their husband, wife, partner, carer, or even family members, and they become more apathetic and irritable. With the MSA, the person has their balance becomes affected, and they can have issues with movement and significant issues with their autonomic nervous system, meaning they can have early issues with breathing and bladder control. And there are also other causes listed there down below: drug-induced Parkinson's, trauma, toxin-induced, and vascular Parkinsonisms. The rule of thumb with the drug-induced Parkinson's, it's normally down to a medication that a person's been taking for a number of years. So the consultant will often, if we can, wean down that medication, and the person will often see an improvement in their Parkinsonian symptoms. We do have an MSA nurse specialist, Samantha Pavey. She covers a big area, so is unable to carry out any home visits, but she will offer telephone support to people with MSA, and will also support us as a team as well in providing adequate support for that person and their family. So this is just a list of medications that we can use for those with Parkinson's or the atypical Parkinsonisms. levodopa in the form of co-beneldopa and co-caldopa, Madapar and Sinemet is still classed now as the gold standard in prescribing with somebody with Parkinson's. Some consultants suggest that if somebody is young, that they would preferably start somebody on a dopamine agonist, because if somebody's on long-term levodopa, especially at higher doses, they can get a lot of side effects. So trying to spare the levodopa and use that at some point later on in the condition, they would start somebody on a dopamine agonist. Not one consultant prescribes the same, so the medication that you start on in discussion with the consultant is very much down to their preference and what symptoms that the consultant and the patient themselves are wanting to try and improve. I don't want to get too bogged down with this slide, but just wanted to highlight there are 5 different dopamine receptors, D1 to D5, and each receptor has a different function. So D1 is more with memory, attention, and D4, for example, is sleep and somebody's impulse behavior. When looking at the symptoms, we need to be looking at where the medication is acting in somebody. Medications can be really complex and really difficult as they come with their own side effects. The main side effect with the levodopa that I always highlight to patients is the nausea. So when somebody is just being initiated on a medication regime with Madapar or Sinemet, the rule of thumb is normally to get them to take it with a meal or with a biscuit or something like that. Once somebody's been established on a regime, we would normally say that a person has to take their medication half an hour before or an hour after food. And like I said before, any sort of treatment with levodopa for a long period of over time and at high doses can produce what we call dyskinesia, sort of wriggling and writhing movements. So that's not somebody's Parkinson's, and it's not their tremor. It's induced by the medication, more so by the levodopa. We're pushing that person above their therapeutic range, which is causing these wriggly movements. When somebody experiences that, some people prefer to be like that as it enables them to be more mobile, but we need to be mindful of stiffness and rigidity and weight loss, as that person will be burning more calories. For the dopamine agonists, the main side effect that I point people to is the impulsive and compulsive behaviours. Now, these can happen on any dopaminergic medication, but they are more likely to happen with somebody who is commenced on a dopamine agonist. So somebody can have high sexual drive, can start binge eating, gambling, drinking alcohol. So if myself or the consultant initiates somebody on a dopamine agonist, we go through these potential behaviours that could happen, and then we also have a questionnaire that we can go through with the patient that they can sign and date, and we give them some literature as well that they can read, so they can go over that when they're at home. So like I said before, carrying on, so there are quite a lot of challenges to medications. As somebody progresses through their Parkinson's diagnosis, they can get a lot of fluctuations, they can get an on and off effect. That's why people end up on lots of different doses of Madapar taken quite frequently in the day. You can get issues where somebody actually takes so much medication and that they actually switch off, and that person is like they're not taking any Parkinson's medication at all. Nightmares and hallucinations and confusion are also quite common, especially in the dopamine agonists, and those who are progressing through and have sort of mild cognitive impairment and are at greater risk of having dementia. The impulsive and compulsive behaviour and the dyskinesia I've spoken about. There's a big Get It On Time campaign that is still ongoing now from Parkinson's UK. Parkinson's medication is a time critical medication, and the person needs to have it on time every time. David and Tracy, who are in the Acute Trust, are doing lots of training at the moment with the ward staff, doctors, pharmacists, and about how they can improve a person's journey when they're in the acute sector to enable them to get their medication on time. Somebody can be taking multiple medications at different frequencies, different timings, and as somebody progresses through Parkinson's, these timings and regimes can become very, very complex. We need to be thinking about a person's diet. I said before about somebody needing to take it half an hour before or an hour after food. This is because the protein interacts with the absorption of the Parkinson's medication, and the protein will win every time. So the protein wins in the transport mechanism, and the levodopa just sits there redundant and until that mechanism is finished with the protein, and then the levodopa can be absorbed. We need to be mindful of somebody who's taking ferrous sulfate. It shouldn't really ideally be taken with levodopa or any of the Parkinson's medication, because it can lose its bioavailability for up to 60%. So they probably won't feel like that dose of Parkinson's medication they've taken has actually been as effective. We need to be mindful in thinking of somebody if they're having some anxiety, low mood, depressive issues, and they may want to be thinking of actually starting some medication to help support the mood. If we're thinking of wanting to also improve their Parkinson's medication, we need to be careful about starting somebody on Visagiline as well as a medication for the low mood, because of the possible interaction and serotonin syndrome. We also need to be mindful that when we've got somebody on the dopamine medications, any of the medications used in Parkinson's, but more specifically the dopamine agonist, that we don't stop any of the medication abruptly. It needs to be weaned off. You can get dopamine agonist withdrawal syndrome. So best practice, even when somebody is in the palliative stages of the condition, we shouldn't just be stopping their medications because their swallow goes, because they're now deemed as palliative. I would encourage any health professionals, GPs, anybody involved in that person's care to get in contact with us, as we're able to convert the medication into a patch form, so that that person has got some sort of cover even in the end stages. And also, if they're able to swallow, we can convert to a dispersible form as well. We need to be mindful when somebody is prescribed medications that they're taking them as prescribed, because you can get, as part of the impulsive and compulsive behaviours I spoke about, you can get dopamine dysregulation syndrome, where a person is compelled to actually take more medication than they're actually prescribed. So they go to the pharmacist, go to their GP, they're running out of their medications more, and they're actually overdosing on their Parkinson's medication. Like I said before, we have our own Parkinson's physio within the team, Deborah Whitfield. Her role within the team is changing quite significantly, so she will no longer hold a clinical caseload herself, but the aim is to have her support now county-wide, so she can go and carry out MDTs, home visits, clinic reviews with other therapists if they're having any issues or concerns with those with Parkinson's and the atypical Parkinsonisms. And she'll also be able to provide training to community hospital staff, like I say, therapy staff. There's lots of evidence now to say that the best management of somebody with Parkinson's is a combination of medications and exercise and that physical activity. And it's been proven that it may help to slow down the progress of the motor symptoms. And you can carry out the exercise at any stage of the condition. And Deb does lots of work with people if they do seated exercises. And it can have impact on not just the person's motor symptoms, but like that's written there, their mood, their walking, their fatigue levels, sleep. And then not an exhaustive list, but just sort of those who we would be liaising with in the MDT for support with those with Parkinson's and the atypical Parkinsonisms. Is there any questions or anything that's come up, Sharon, up until now?
Not yet.
Sorry, I know, I appreciate we've got somebody else speaking as well afterwards, so I am just flying through the slides. I have got a couple of case studies now. If you want to put some of your thoughts down in the chat that Sharon can pick up, or if you wanted to turn your microphones off to give us some answers, that would be great. So case study 1, these are real life case studies. This was a 24-year-old male who lived in a residential home in Lincoln. He had a diagnosis of idiopathic Parkinson's that was given in the year 2000. He was on Madapar, 125 milligrams, and he was taking 1 tablet 7 times a day with a controlled release preparation overnight. Also had some issues with blood pressure, so he was on the fludrocortisone to help prevent that postural drop. Taking other medications as listed there. The Parkinson's nurse carried a review out in May of this year, and there was nothing abnormal noted, no referrals needed. Everything was ticking along quite nicely at that time. In June, we had a request for an urgent Parkinson's nurse review due to a significant and rapid deterioration in mobility, cognition, behaviour, and this chap was experiencing hallucinations, frequent falls, one of them which led to him to go to hospital, which he had an MRI scan, and they were still awaiting the results when this came through, and he'd been treated twice with oral antibiotics for a UTI. So just wanted to know what your initial thoughts were. What actions do you think should be taken or should we have considered? I'll just pop that slide back on so you can see. Anybody wanting to have anything come through, Sharon?
No. They're all being very quiet.
I hope that's a good thing, a good sign. Well, I've highlighted here urgent and significant rapid deterioration.
Oh, hang on, Amy. Somebody said review the medication.
Yeah.
Somebody wants to know what an NAD is.
No abnormalities detected. So it was a normal review. There was nothing, no issues or concerns or anything that were highlighted or picked up at that review.
Judy's also got her hand up. Judy, have you got a question? Oh, you're on mute, I think. Can't hear you, unfortunately, Judy. Are you able to pop your question in the chat box?
Want me to carry on?
So somebody's asked, check if the urine infection's clear.
Yeah.
Helen says get a GP or the practice care coordinator review, which we do quite a bit, don't we?
Yeah. Yeah, that's fantastic. And that's exactly what really should have happened in this case. When I got to the care home, it was not appropriate at that time for myself to do a Parkinson's nurse assessment. I assessed him top to toe. There's his observations there. He had a really low blood pressure of 80/40, really fast pulse at 115, fast and shallow breathing. He had no bilateral breath sounds to the lower bases. He was shortness of breath. And I think the main factor here is that sudden and rapid decline. So with Parkinson's, if something is sudden and rapid and there's a significant decline in that person's Parkinson's, it often is the indication that it's actually not their Parkinson's at all and it's something else. And we need to have the GP, practice care coordinator, the nurse practitioners to go out and assess the person to rule out underlying infections, rule out any issues with constipation. Your Parkinson's medication is absorbed in your bowels, so ensuring that somebody is having regular motions is really, really important as well. So yes, we like to try and avoid hospital admissions in those with Parkinson's, but in this instance, this was not at that time. He was admitted to Lincoln Hospital and was treated for urosepsis and chest infection. And since coming back to the care home, he's had no further episodes of confusion, and he's now working with a physiotherapist with his mobility and his walking. Just to pick out and just to say that those who are admitted to hospital with Parkinson's, you will find that when they are discharged, they will not quite reach or be back at that baseline that they were when they was admitted to hospital. They will sit just underneath that. So you will note some deterioration in that person when they are discharged from hospital.
Amy, someone said, asked, has he been assessed for dementia, which is a really good.
Yes, that is a really good. I did say to the care home staff while I was there that once the infection and things had been cleared and have been treated, if the confusion was still an ongoing issue, that was next on the list to send an email off to the mental health team to see if we could have a memory assessment. I did think that if that continued, an underlying dementia could be emerging. Yes, that's really good. And then case study 2, he's a 76-year-old gentleman who lives in Grantham. independent with activities of daily living, lives with his wife. He got diagnosed with Parkinson's in 2017. He was on a few concoction of medications. Sinemet, he was taking one of them 7 times a day, Rizagiline and amantadine. He had regular nurse support, face-to-face and telephone consultations. But he had quite a few issues then. So soon on in his diagnosis, he started having sort of daily falls, reduced mobility, swallowing issues, and he had a very poor response to medication. He was becoming more reliant on his wife for support with his activities of daily living. I did refer quite early to the MDT with speech and language, our Parkinson's physio and occupational therapy. He had a couple of hospital admissions and for UTI and delirium, and he was treated for urosepsis and type 1 respiratory failure. And following his hospital admission, he started to intermittently self-catheterize as well. So again, any initial thoughts or what actions do you think that we should have looked at or taken or considered at that time? I'll just pop that slide back up again. Anything coming up?
Not yet.
So when somebody's
just about to say, somebody has he been weighed because he's been unable to swallow?
Yeah.
So I suppose we've been monitoring his nutritional status.
Yeah, definitely. And when somebody does lose weight with Parkinson's, they can have more side effects from their Parkinson's medication. The dyskinesias, like I spoke about before, can commence or become more can become worse, can't they? So yeah, monitoring weight is really good.
So we've got a few things flying in, Amy. We've got a couple of people have asked, have we checked his diabetes? How stable is it? Mm-hmm. Is he taking the medication correctly?
That's good.
Should we be looking at liquid medications?
Fantastic. Yep. That's brilliant, especially with the noting the swallowing already. Yeah, that's fantastic.
Are the swallowing issues causing him to not take his medication on time? Does he need OT support for assessment and equipment?
This gentleman had, Deb did get involved quite early on in the diagnosis, and he had a very marked goal that he wanted to achieve. His daughter was getting married and he was adamant he needed and wanted to walk her down the aisle. So Deb worked with him quite vigorously, and he actually met the goal of walking his daughter down the aisle. But obviously soon after that, he took a bit of a downward turn, but yeah, he did end up meeting that therapy goal, which was really nice.
So with I was just going to say, somebody's just mentioned if we'd asked the wife if she needs extra support, and I regularly say, in fact, I said it today. I was seeing a patient this morning. It's a bit of a joint effort. Parkinson's is a bit of a joint effort. It's a 2-man approach because I think it affects the partner just as much in different ways as it does the actual person with Parkinson's.
Definitely. And I don't know about you, Sharon, but sometimes you can get people coming in and saying everything's fine, no, I'm fine, and then you actually ask the partner, or they chip in with some answers and say, well, actually you're doing this, or this is an issue. So yeah, definitely, that's fantastic. Carer burden, carer stress is really, really high.
Yeah,
that's fantastic answers. So with this gentleman, he continued to have rapid decline, and there was lots of red flags that were coming up. I had a discussion with him and his wife, and I didn't think we was actually looking at Parkinson's as a diagnosis. I thought he had more of the signs and red flags quite early on of multiple system atrophy, MSA. I had a discussion with his wife about this, and I wrote in my letter to the consultant and asked them to consider the diagnosis of MSA and why, and what my rationale was for. The consultant called them into clinic and reviewed him face-to-face, and did actually agree and change the Parkinson's diagnosis to MSA. So because of that, we went from the Parkinson's diagnosis sort of pathway onto the MSA pathway. Like I said before, less than 20% have a response to medication. So in this instance, the medication was causing so many side effects, so we ended up weaning and reducing him. So this patient is actually no longer on any Parkinson's medication. We've got the MSA nurse specialist involved, and she calls them to offer support. We got the St Barnabas Inn and palliative care team. He's now palliative. He's nursed in bed, with his wife. His wife supports with all the activities of daily living. And I did a CHC checklist, and following a DST, he does have funding in place as well for carers. But in fact, I actually went to see him yesterday. So it's just, I like to put this case study in because I think it highlights that because somebody's got a diagnosis of Parkinson's, it doesn't mean that that diagnosis is going to stick throughout that person's whole trajectory, whole journey. You can get diagnosed with Parkinson's, but then something can happen. Red flags can occur quite early on in the diagnosis. It's quite evident that somebody's not got Parkinson's, they've got MSA or PSP. And actually, in some cases, I've had a gentleman in Sleaford who was treated for 10 years with Parkinson's medication, and the consultant said to him one day, "I actually don't think you've got Parkinson's," reduced him off his medication. There was no worsening of symptoms, and he no longer has Parkinson's. So just to sort of bear that in mind. This is the sort of a resource list. We've got Parkinson's UK helpline. It's a free phone helpline, and you can speak to a nurse on there if we're not available, if you're wanting any help or support. We've got some training as well, which is fantastic on there, and looks at the pathway for nurses. You've got the NICE guidelines, and I like there the PSP and the CBD red flags. You can go on that, and it gives you a nice list of those sort of red flags we should be looking out for when assessing somebody with Parkinson's. And I popped the brain bank criteria on there as well. Any questions?
Helen's got her hand up.
Hi, Amy. That was really interesting. Thank you. I'd just like to ask, where are the local Parkinson's support groups?
Oh, that's a really good question. We don't have one in Sleaford anymore. The one in Sleaford is more aimed at carers, so those who have a husband or wife or somebody with Parkinson's. We do have one, don't we, Sharon, in Grantham, that's at Manthorpe Church. Is that on a Wednesday afternoon now? I think they've changed it, haven't they?
It is, yeah.
Is that every Wednesday?
I think so. Or is the one Wednesday they don't do? I think is it the last Wednesday of the month they don't do?
Yeah. They've changed it because it's going into sort of more winter months and things like that. I shall send you over the programme, Helen, because they have a physio that goes there and does seated exercises and dance and things like that. When it gets near Christmas, they have wreath making, and they've got their Parkinson's dinner that they arrange at Belton Golf Course. They have lots of days out and things like that as well. So
that'd be great, because that's something I could really use. Thank you.
I'll send that over.
Thank you.
There's another question, Amy, from Natasha Smith.
Hi, Amy.
Hello.
Hi, Amy. Would you be able to send me that information over as well, please, what Helen's just asked for?
Yeah, I will do. Yeah.
Thank you.
Amy, if you send to me, I can send out centrally to the whole group if that would be helpful.
Yeah, I'll do that, definitely.
Thank you.
I know there was a lot of information and a lot to take on board, and like I say, dealing with those with Parkinson's and their typical Parkinsonisms is very complex, but I hope it gave you just a bit of a whistle-stop tour on sort of meds and things like that. And
It did, thank you. It's really useful. Lots of information packed in there. And Amy, are you happy for me to share the slides afterwards for people's future reference? That would be ideal. Lovely, thank you. Any further questions on anything related to Parkinson's?
Another question from Nicola.
Hello, so I'm the Ars Health and Wellbeing Coach Lead, and I just wondered, from a behaviour change point of view, what kind of focus would you like the health and wellbeing coaches to have when they're working with your patients?
A lot of our patients have issues with sort of apathy, low mood, anxiety, but and I think it's sort of the husband-wife carer who are really struggling with the changes, especially when they become quite irritable and things like that. So maybe coping strategies and anything that they can do that they used to enjoy doing that but maybe no longer do, but it's quite easy for them to maybe slip into that I'm not going to do it because I can't be bothered or I haven't got the motivation and things like that. Looking at things they used to enjoy that they can still, like normalising. I quite say to people with Parkinson's that Parkinson's has got to live with you and not the other way around. So trying to keep it as normal and as active and healthy lifestyle as possible.
Yeah, thank you. That's really helpful. Thank you.
And Judy has a question. Can't hear you, Judy.
No.
I think maybe your microphone's not working, Judy. Do you want to pop the question in the chat?
Sorry, can I ask a quick question, Amy?
Yeah.
I'm putting you on the spot. Is, you know, when somebody's diagnosed with Parkinson's, are they automatically referred to your team, or do they self-refer, or?
As long as somebody has got a diagnosis of consultant diagnosis of Parkinson's and they're registered with a Lincolnshire GP, we can accept self-referrals. Normally when they've seen the consultant will copy us into the letter, and then that generates a referral in itself, and they will send out a new patient letter and a copy of our service leaflet and anticipatory care plan, which just highlights, you know, watch out for constipation and if there's any significant sudden decline, is there any infections going on and things like that. So they should do, but sometimes there are a few that are missed, aren't there, Sharon? So yes, as long as they've got that diagnosis, we'll accept self-referrals as well. Yeah.
That's brilliant. Thank you.
So Judy wants to know, do we refer our patients to the Parkinson's nurse, and if so, who to? So we accept them in as a team, don't we, and then allocate them out according to the geographical location.
Yeah, so you can refer into that email address that was on our slides, and that comes to our admin team, and they'll place a referral on the ledger, and then we use System 1, so we get tasks. So anybody that calls in or makes any referrals, they'll go via our admin team, and then they'll task us, and we triage them throughout the day, red, amber or green, depending on need. Yeah, our new referrals are triaged as amber, so we like to get them sorted and our details out quite soon, as we know that getting a diagnosis of Parkinson's can be, you know, it's quite a shock and quite a big thing to be diagnosed with. So if we can get in there soon to offer our support, that's better. And any issues, or you're unsure who to go to, please just give us an email, give us a call, and more than happily help and point you in the right direction.
Lovely, thank you, Amy and Sharon. As discussed, I've got a copy of your slides already, actually, so I'll send those out to the group. If you're happy to send across the information that you shared just now as well, that'd be ideal, and I'll include that in the email. Just looking at time, we're running a little ahead of time, which is always good. We'll have a coffee break. I don't believe Laura from Carers First is on the call yet. I think she was going to join a bit later, but I'll just drop her a quick email and see if she is able to join a bit earlier. So we're currently at 20 to 2. Yeah, in fact, I think to avoid disrupting the afternoon too much, let's take a slightly extended coffee break and join back just after 2 o'clock. And hopefully by then, Laura will have joined the call. Thank you, Amy, Sharon. Really appreciate the time. Hi, Laura.
Hi, Ruth. How are you doing?
Yes, good, thank you. You?
Yeah, good, thank you.
Good. Thank you for jumping on a little bit earlier.
No problem at all. It's quite peaceful actually when you're safe in the security of a Teams meeting. It's nice. A few minutes to reflect.
Yeah. Right, I'd say 2 o'clock, so we'll kick off when we hit 2.
Yeah, no problem.
Right, just turned 2 o'clock, so welcome back, everyone. I'd like to introduce you to Laura Blaine, who is Carers Practice Lead at Lincolnshire County Council in the Public Health Division. Laura's going to talk about the Carers First service and how you can refer in. So yeah, over to you, Laura. Thank you.
Thank you, Ruth. Ruth, can you how long have I got again? Just remind me, is it 50 minutes?
Yes, yeah. I think just double check the schedule again. Essentially, we've got till 3 o'clock. So
okay,
yeah,
lovely.
Flexible on timing.
So plenty of time. And could you just give an overview of the roles of the people on the call, Ruth? Is it a variety of?
Absolutely, yeah. So I don't know, do people want to pop the roles in the chat? I know we've got a mixture of care coordinators, social prescribers, and health and wellbeing coaches.
Fantastic.
But I know not everyone who's signed up has managed to attend. So if people are happy to put, as we've got a bit of time, if people are happy just to put the roles in the chat, it'd be really good to see who we've got on the call today.
Thank you, Ruth. Thank you, Jeanette. Lovely. She's fab. Fantastic. Thank you.
A good mix, it looks like.
A really good mix and a variety there. So I'm imagining I'm going to be talking to some of you and you will have a bit of an understanding about Lincolnshire Carers Service, so promoting independence therapy assistance. Oh, fantastic. Okay. Lovely. And that's fantastic. It does help for me to understand who's on the call, and it's lovely to be invited, to be honest. I think part of the role about the Lincolnshire Carers Service is this never-ending kind of commitment to make sure that people know about what the offer is in Lincolnshire. And of course, the world of carers is so broad that we cover so many colleagues that it really is a never-ending kind of challenge to make sure that people understand what the offer is. I have got a PowerPoint, and Ruth, tell me if it's suitable. What I was going to do, I really wanted to keep the session as informal, as interactive as possible. I was going to round up everything I shared today in an email and send it out to the group with that PowerPoint on. I think sometimes PowerPoints, they can feel, instead of looking at the screen, it's sometimes nice to just talk on Teams because it can feel a bit exhausting. So if that's okay with everyone, I'll send on the information following this session. I'll introduce myself first of all then. I'm Laura Blaine. I'm the Carers Practice Lead for Lincolnshire County Council. Been in post for nearly 2 years now. And what my role is really here to do is to make sure that the practice within Lincolnshire, the way we support unpaid carers is as good as it can be. Lincolnshire County Council contract with 2 providers to deliver the Lincolnshire Carers service. So Ruth has just mentioned Carers First there, which is one arm of kind of the model. We also have our colleagues over at Serco at the front door of our Lincolnshire Carers service. So when we refer to our offer, we call it the Lincolnshire Carers service. I'm going to talk a little bit about the internal who's who, but for carers out there in the community, I don't want them bothered about our model. Do you know what I mean? Because what we've done is we've delegated that duty to our 2 providers, but carers have got enough to be worrying about without thinking about how our model works. Essentially, what we want to do is to make sure that carers know where to go to access support, and understand what the point of being referred into the service is. And as we know, for many people, they don't consider themselves an unpaid family carer at all. They consider themselves mum, dad, sister, brother, could be an aunt or an uncle, could be a friend, or it could be a neighbour. And therefore, why would you come to access support from your local authority? For some people, that can still feel quite an alien thing to do. But we, of course, know that the preventative element of accessing that support can be really significant. I think I'll just touch on this before we go into thinking about the people we support in our communities. Caring affects all of us at some point in our lives, and I know some of you on this call today will no doubt be caring for family members. It can happen to us at any point as well. We can instantly become a carer without any kind of warning as well. I know within Lincolnshire County Council we do have really good staff support networks for our employees who are caring. Now, I know I've been speaking to Joe Ralston over in the NHS as well about the NHS offer for working carers as well. So just that bit of a caveat before we go into thinking about people we support within our own roles, it's thinking about yourselves as well. If what I talked to you about today kind of hits home and you suddenly think, oh, I'm caring actually, all of this information applies to any one of us if we're in Lincolnshire, that you can access that information as well. And there are numerous support networks for carers. LPFT, NHS, LCC are all committed to supporting carers, and it remains a priority in terms of kind of our themes that across the board everyone is committed to. So I just wanted to talk about that very quickly as well. We know that working carers leave the workforce over 600 per day in some instances, and actually maintaining employment and caring can be a real challenge. So it's really important, if you are working and you are a carer, to get that support that is out there as well. Okay, with none of you having your cameras on, I think what I might do is get the PowerPoint up and then I'll not have to look at me. Ruth, can you confirm that you can see that?
Yes, I can see that, Laura. Thank you.
Lovely, thank you. Okay, so just a couple of quotes here, just really, really interesting. Rosalind Carter, the former First Lady, once said, there are 4 kinds of people in the world: those who've been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. It is frequently forgotten, or perhaps worse, taken for granted, that the majority of care provided doesn't come from the NHS or from care homes. It comes in the form of unpaid care, which relatives, friends and neighbours provide. And that quote comes, that information is from Carers UK. Would anyone like to have a guess at some facts and figures? If you want to shout out, go for it. If you want to put it in the chat, go for it. How many unpaid carers do you think there are in the UK?
I'm probably wrong. 3.9 million.
Okay, thank you, Natasha. Anyone else? Any other takers?
I don't know whether you can see the chat, Laura, but
I can't see it. If you could read it out, Ruth.
Absolutely, yeah. Several people saying 11.5, three people saying 11.5, 2 saying 5.7.
Lovely, thank you all. Do you know what? After the last census, it came out at 5.7 million, but I think realistically, evidence is suggesting it's more like 10.6 million. The census question, the way it was worded, changed last year from the previous census 4 years before that, and I think it was during COVID, wasn't it? And I do think that it's acknowledged that some people during that time found it even more difficult to identify themselves as carers, and also that wording probably didn't help. So officially 5.7, but thinking more towards the 10-11 million mark. How many unpaid carers, anyone, are there estimated to be in links? Sorry, Ruth, if you could be my assistant.
Yeah, absolutely, no problem. Okay, got people going for the middle column, 48,000.
48,000. It's actually 88,000. We have many carers obviously in Lincolnshire, and of course we're not, through the Lincolnshire Carers Service, we're not reaching all of them, and we never will. Many people will never access the service, but what we want to do is to make sure that people are clear that there is a dedicated service there and it is open to them, and it is tailored to their needs. So yeah, 88,000. How many NHS staff provide unpaid care?
Got a mixture of answers coming through. Most saying 1 in 5. Someone saying 1 in 10.
Yeah, apparently 1 in 3. So I just had a very quick look on the Carers UK website before I came on. Of course, the stats research is going on continually. This was from an NHS survey in 2022. Apparently 1 in 3 NHS staff are providing unpaid care themselves, as well as delivering support to the people that they see every day in work. And nationally, the carers' unpaid contribution each year yeah, 162, 120. Thank you. So they're all coming through now.
A range of options, yeah. I've got people going for all 3 answers there.
Yeah, all 3. It's quite staggering, isn't it? The answer apparently is 162 billion, so the equivalent of more than another NHS. So I don't know if anyone wanted to offer any reflections on that. Any of those stats, are they shocking? Are they kind of what you'd expect being in your line of work already? I think they always still shock me when, even though I'm delivering this information quite a lot, it is shocking, isn't it? Yeah, I think so. And of course, we know that family members aren't going to down tools and say I can't do this anymore all at once. But we do get calls from people, yeah, regularly, where they're on their knees and they're saying I can't do this anymore. But essentially, we all see the value in supporting carers from the beginning of their caring roles where possible, and you being out there, being the eyes and ears. If we can get people to understand that there is a dedicated service, which I've no doubt some of you do already, then we're doing our job. Yeah, carer burnout, fatigue. What we want to do is make that caring role sustainable with good information, advice, support, which is exactly what we aim to do. But the fact that, yeah, 162 billion, and people do, when they come into the front door of the service, their expectations are relatively low. They want to be listened to in that first instance, to carers. So, yeah, some interesting figures on the situation. Okay, I am going to put this link in the chat. Do you think you'll be able to access YouTube? I'm just going to put it in the chat, and then hope that you're able to watch. It's a 5-minute video about a young carer called Samuel. I thought it'd be nice if we could all watch it and then come back for some reflections, and some questions and discussion. I'm hoping if I put it in the chat now, playing it unfortunately through the PowerPoint, the sound doesn't always work. So I've gone for the easy option of putting it in the chat. With you all having your cameras off and your mics off as well, can you just give me a thumbs up if you can see it and you can access it? Yeah.
Yeah.
Helen's got it. Lovely, lovely, lovely. Okay, right. So it's if we say come back at 20 past, it's just over 5 minutes long. I will just say it comes with a bit of a trigger warning. It is quite hard hitting. You've all got your cameras off anyway. I would have suggested turning your cameras off if you didn't want anyone to watch you watching it. But yeah, when you come back in, put your hands up so I know that you've returned. Okay, so we'll come back at 20 past 2. Thank you.
Laura, I think you're talking, but you're on mute, so we can't hear you, I'm afraid.
Sorry, that's probably a good thing. Is everyone back? I was thinking, oh, maybe they're not back yet. Any reflections? Any initial reactions? Thank you for the comments that people have made. I think the point about the the paid care work only being there part-time is one that comes up quite regularly. Does it seemed unfair to quite a few of you, and I suppose quite upsetting. And certainly that's not the intention of why we show it. I suppose what we want to do is to think about the fact that this is happening all the time for young carers across our county. And adults are in a similar role caring for their loved ones as well. How do you think Samuel will be affected then? Oh, is it echoey?
The sound seems to be okay this end.
Does it?
If everyone could just put themselves on mute, that might help. I'll do the same.
It's okay with me. You're not echoing.
Okay, I'll keep going. It's just sad. He has an enormous amount of responsibility on his shoulders. Yeah. He is an amazing son, absolutely. Any positives from anyone about the video? Yeah, Helen, absolutely. The love they share, that bond between Samuel and his mum, and the care worker being incredible at working as a team with Samuel. They really did have that nailed in terms of the process about what to do, and they both remain very calm, didn't they? Although it is a really shocking situation. Separation anxiety, Charlotte. Yeah, it seems to be very loving child. Absolutely, and this is going on, yeah, day in day out. We had someone comment the other day about kind of children in need and that promotion of young carers during that event. But of course, it's our duty really to make sure that we're identifying those young carers all the time. And okay, what is the process to support those young carers that you might come into contact with in your role, which we'll come on to in a moment. So Martin said, the beauty of a child's mind, that is just normal. Yeah, absolutely. And he takes it in his stride and without problem. I think that part of the video at the end where they're running off together and they're happy, obviously mum being pushed in a wheelchair. Yeah, there is happiness there, but it does raise questions about Samuel's future. And just when I was reflecting while you were watching it, I was just thinking it'd be really nice to know what's happening with Samuel right now, because I think this video is quite old. So I might do that, check in. I think he's in he's certainly out of county in Yorkshire. Nicholas said he must worry what will happen to him if his mum is no longer here. Yeah, absolutely. And at home. So I didn't want to for it to be upsetting. That wasn't the intention. It was just to think about young carers in general and our responsibility to try and signpost appropriately. Okay, so I'm going to move on to what the Lincolnshire Carers Service offer is in Lincolnshire, and I'm thinking that some of you will have a little bit of information already. You could have already referred into the service. If anyone wanted to share that they have, that would be really appreciated. We do now have some leaflets you might be pleased to know. I'm certainly very pleased about. And that branding has been agreed. So if you wanted any leaflets sending out, or I'll certainly send them e-versions of those leaflets after this session on my email, and we can get those out to you, because we know for some carers digesting all the information at once can be quite overwhelming, and they might want to read that leaflet when they've got a moment to themselves, which might be much later on in the day or week or month. Yeah, that's fine, Natasha. Yeah, I think hard copies, I can't imagine ever getting to the stage where we don't want hard copies of leaflets, but I think that's what people want. So I'll sort that out afterwards with Ruth, absolutely. Yeah, no problem at all. So as I said, it's the Lincolnshire Carers Service. We have 2 delivery partners. So we have delegated our statutory function to Carers First to complete our carers assessment duty as a local authority. But we have 2 partners in the arrangement. We have our Care and Wellbeing Hub over at Serco, who take all the initial calls from carers, and I'll send you the details about how to make referrals on the email. Everything funnels through that front door at Serco, and what we do at that point is we have a conversation with our carers. There is a strengths-based conversation, and it is tailored to them. When people come on the telephone, they don't necessarily know what it is that they're looking for or asking for. They've only just figured out in some instances that they are a carer themselves, and it can feel quite daunting making that call, or actually acknowledging that they need a little bit of help. So those calls are really sensitively handled over there at the Serco team. There can be a number of outcomes following that conversation, but they would be followed up 12 weeks later to make sure that the information, advice, guidance, the links that we send them have made a difference and have worked for that individual. Okay, so I just want that point about everything going through the front door means that we've got a really good understanding about what the demand is for our service, and again checking in continually that we're getting this service right for carers. It could be that during that conversation those carers want to be referred on to what we call our universal offer. I don't know if anyone's heard of the universal offer. Carers First deliver that part of the service, but it could be that a carer really wants to go on a first aid course to learn about dealing with an event of an emergency with the person that they're caring for. Carers First run some learning courses that for some carers are really, really important. They also have wellbeing groups. They have pie and pint groups. They have archery sessions. They have wellbeing sessions. They have walking alpaca. All across Lincolnshire, and on their website is fab. You can do your locality areas and see what groups are available. Okay, so when we're having this conversation at the front door, it could be that a carer says, oh, I absolutely would like to meet up with other carers because I never get a chance to go out of the house. And that really is something that I'd like to achieve. For other carers, they'll go, I definitely don't want to meet up with other carers. That is a total turn off. But what I really want to do is get back into employment. We also have employment support for carers looking to get back into work, and we have the benefits team over at Carers First who can support families to make sure that the income coming into that household is maximised, because as we know, financially carers are really up against it, and often not in employment because of their caring roles. So making sure that all the benefits that are accessed appropriately is really, really key. Okay, so we've got under that universal offer. I'm not saying they're kind of fluffier bits, but if you like, there's a whole range of services there that can be really, really life-changing for carers. Okay, so conversation could lead on to the universal offer, or it might not. They might just be happy with it. That carer might just be happy with a bit of information. We also have the legal right to a carer's assessment that is delivered by our Carers First team. I don't know if any of you have ever seen a carer's assessment or had a read of one, or someone said that they've had one. Nicola, did you want to? No. But that is a legal right, and for some people really, really important to them to have the local authority listen to them about their caring role and consider a number of themes under the Care Act, and consider the carer's well-being is really, really critical. For some carers, as we've said, assessment isn't what they want to go through. It's not for them, but for some carers it really, really is important. We don't have a really high threshold for people accessing our Lincolnshire Carers Service. The reason for that being, we understand the preventative element of our service. If we can reach carers, the sooner the better, basically. that people can maintain their caring roles, feel informed and supported throughout. So there's not a kind of criteria to access our service. Outcomes from the carers assessment could be, I don't know if any of you have heard of Carers Emergency Response Service, where a carer could set up a contingency plan as to what might happen if the carer was unable to continue caring in an emergency scenario. For some carers, that provides an enormous kind of peace of mind, that they've talked through, okay, in this instance, this is what I'd like you to do. I'd like you to call my sister who lives down the road and would be able to step in for me. Some carers in Lincolnshire do not have any family members that we can call upon, and then it'd be reverted to our adult social care practice. But that peace of mind that carers emergency plan brings is really, really important to people. And also following the carers assessment could be a whole host of options that are considered, but a carer's personal budget could be another outcome. We do have money that we do give to carers, and the usual uses, the highest kind of most frequent uses of the carer's personal budget, having a break from your caring role, paying for a cleaner, paying for a gardener, accessing gym membership. There isn't a financial assessment related to our carers' personal budget. Obviously, adult social care work differently regarding the individual on their personal budgets. We're not means testing anyone. We want to keep that as accessible as possible. But I will say really clearly that we don't get people knocking on the doors, our door for that money. That comes at the end of a thorough carers assessment, where we will exhaust every other avenue of support, including financial support, before we even look to the carer's personal budget. But that's not to say for some people that money can be life-changing, and it is about giving sometimes people permission to go to the gym even though you're caring, and that comes with often quite a bit of hard work around. It is important to maintain your own health and well-being. So, sorry, going back to that slide there, that's the referral pathway. I do not expect any of you to retain all of this information. I just want you to know that I will send this on so you've got it to hand, so you understand the pathways of what can happen following that initial carer conversation. The key highlights for me of this is we have a dedicated workforce between Serco and Carers First of over 50 odd staff, purely there to support carers in our community. So I obviously feel really pleased with what our offer is. It's extensive, it's personalised. They're there looking out for carers constantly, and we can't work in silos, as we know, and we have to work in that joined up approach. I'm continually working with NHS colleagues, with children's colleagues, third sector colleagues, to make sure that we understand what the offer is from each other's services. And I know you all do an amazing job of signposting people every single day. So that slide there just gives an overview of kind of the offer of the Lincolnshire Carers Service. And if we're seeing themes at the front door where people are saying we really want a support group to help us with this, it could be that we then commission that service. Do you see what I mean? We have to adapt to what the needs are that are presenting. We're going into winter. Still, cost of living is a massive issue for many carers, inflation affecting many carers. So we really want to make sure that we're getting the right information to people about heating and winter pressures. Okay, that's the Carers Emergency Response Card. I've just put that on there. Carers carry around, it's like your Tesco club card key fob, where you've got your special number on there and that links to your plan that's on the system. Okay, and then I've put some resources on there as well, just quite general. Our Connect to Support website is really useful. The Carers First website is really useful, but you've got all that information coming to you on the email. Okay, has that stopped the PowerPoint? I think it has, hasn't it? Okay, so in a nutshell, I wanted to give you that kind of just a glimpse into Samuel's life. This is what's going on for many people across Lincolnshire right now in many different guises. I know that's not lost on all of you, but we do have a dedicated service in the county that is really quite simple to refer into. Can anyone tell me that they've referred into the service and if it was simple or not? Because I'd love to know. Yay, Helen, thank you. It's always a risk, isn't it? Yes, many times. Fantastic. So I am speaking to the converted, basically. You already get the point. Okay, so Vanessa, when you said refer to carers first, I'm just going to pick you up on that. Was it the Lincolnshire Carers Service you went through the front door with everything funneling through the front door now, or was that before when you used to be able to go through to carers first directly? You've just signposted, some people have signposted.
It was direct with carers first.
Yeah, so I just wanted to bring up that point because before October last year, the contract was set up so people could just go directly to carers first and they could go via Serco. Since October 2022, we changed the model because we couldn't keep track of who was coming in and what the demand was and what we needed to in terms of resources. So now, just to give you some context about why we funnel everything through the front door. I hope that makes sense. It's not to put a barrier in place for people. It's just so we've got a really good understanding of who we're supporting and that we're getting our service right. Thanks, Helen. So how would you refer? How do you refer? Do you give the carers the e-referral portal to do it in their own time? Or would you just, you'd maybe signpost them to that or give them the telephone number? So if I got you some leaflets, then you've got those leaflets accessible. I'll tell you all those different ways, but the e-referral portal for, again, carers who don't have a minute to themselves until kind of late at night, it's a really simple way of referring into the service themselves. So I would recommend. And what I would ask as well, 01522 782224. That hasn't changed, Jeanette. But I will send that on the email as well.
If you don't mind, Laura, because I have phoned a couple of times and I've sort of got diverted to a different number. They've given me a different number.
Have you?
Yeah, and I don't know why that was. I wasn't really sure. They said it was to do with something to do with well-being, and then I got transferred to a different number.
Were you making a referral on someone's behalf then, Jeanette?
I was, yeah. I got their consent, yeah.
Yeah, absolutely, which is part and parcel of what you do, isn't it? Now, when you speak to that advisor on the phone, you can imagine those advisors are taking a lot of incoming calls. If you can really, and I'm sure, I've no doubt you were, but it's important. If you think the Lincolnshire Carers Service is the best option, just try and make that as clear as you can. Because well-being, they offer quite a few similar services to what we do, so I do understand sometimes there can be a bit of confusion. But yeah, that is the way in. That number hasn't changed.
Are you putting? Did you say you're sending that through on email, Laura?
I'll send it all on email, so it's really clearly laid out for you. Absolutely.
Brilliant.
But what
it was a couple of months ago that was, and I know they was really busy because it took quite a while before they answered. So I know they were really busy because we did have a chat about how busy they were. So whether that was something to do with it, I don't know.
Well, look, I think it's really important for you to understand we're all part of the system.
Yeah.
The carers team don't take those incoming calls. The adults team for adult social care take those incoming calls, because you can imagine the carers team are making outbound calls, so they're not available. So what that adults team do take those initial calls, but we need to make sure that whatever you refer is getting through to the right team. If you ever want me to chase up a referral, do you have access to Mosaic? Sorry, I should have asked this at the beginning. You don't.
We don't. No, we don't, okay. Laura.
No, okay. So, but you could always get in touch and say, Laura, would you mind having a look if you're wanting to know the outcome of what you've referred in? Just for that reassurance, if you've got a case that you think I really do want to know, and you've maybe not got any information back, I'm more than happy to help you all. But certainly
that'd be brilliant.
No,
thanks, Laura.
No problem at all. I think what I'd ask as well is that commitment. If you refer anyone, which is amazing, if you do, it's just managing that expectation. And not offering that kind of, right, they'll do this, and this. That conversation will be where the carer's needs are established, and what's going to happen next will be explained really thoroughly. If that we'll ring them back after 12 weeks, and if what we've offered doesn't hit the spot, then we'll look again at, okay, what's changed, how can we support you? But of course, sometimes if people are coming through and that expectation's been raised in terms of they can put a carer's personal budget, or I just, as I know you will do, just to say, look, I think it'd be really good if you had a conversation with them. They'll talk you through the process, without raising that expectation about what the outcomes of that conversation or assessment would be. Because carers might tell you one thing and then they'll get on the phone to us and tell us another thing about what they need help. But that's just what happens sometimes, isn't it?
No, I always do that.
That's brilliant.
Do any expectations or anything.
That's amazing.
All right, thanks Laura.
Thank you, Jeanette, absolutely. So yeah, you've not got access to Mosaic, so those referral routes are your telephone call in, get the carer to do it themselves, or if you really think they're unable to, that's something you could do, or that e-referral portal that's on our website that I'll send you the link for. Really straightforward. Get you some leaflets, some hard copies as well. I don't know, the neighbourhood teams meetings, do some of you, sorry, this might be a really daft question, I presume some of you sit on the neighbourhood teams meetings and you might have met some of the Carers First workers, the colleagues in your community, yeah? Do you link in with them? Would their work phone numbers help you? I'm just thinking, to understand your roles, is there ever a case where you think, oh, I could really do with speaking to that worker from Carers First? I'll send you the numbers as you've got them. Yeah, you have such busy roles, and you're doing it already. Okay, I don't want to overwhelm you with stuff that isn't appropriate. It's always really hard to glean what works for everyone in their roles, but some of you clearly are linking up closely with them anyway, and if you're not, that's great, Helen, brilliant. If not, I'll send that so you've got their work numbers as well. What I will say, Carers First are a national charity. They can tap into pots of money that we as a local authority can't, and they will exhaust every avenue of support. They've got short breaks access, they can get free SIM cards, they do no end of fundraising stuff as well. That's absolutely fantastic. So as our kind of provider, who we've delegated that statutory duty to deliver our carers assessments, actually they're a really knowledgeable bunch, and they really do some amazing work with some really kind of sometimes complex families where there'll be chains of carers and everyone will be caring for each other as well in some instances. So certainly we want to make sure that we're getting the most from Carers First and you all in terms of that partnership working. Okay, I could talk all day about Carers Services. I know you've already listened to one. I think you've been learning. Parkinson's colleagues have been on, which I would have loved to have attended. Actually, I might have to link in with that speaker. Ruth, does that kind of hit the mark in terms of today's session?
Absolutely,
from your point
Laura.
of view?
I think that's been really helpful, and particularly judging by the comments in the chat and the engagement, I think that's been really beneficial. So thank you for taking the time. It's also nice just to have a more informal chat rather than too much PowerPoint. I know certainly you kind of have death by PowerPoint. So yeah,
it's hard, isn't it? Yeah,
it's really useful as well. So thank you, really appreciate it. If you're happy to send across the slides that you did share,
I'll send everything that I've talked about. Yeah, and I would ask I would ask for that commitment from you all, as well as the people you're supporting in your work. Think about yourselves, think about your families and friends, and it might be that you go home and say, did you know there's a dedicated service in Lincolnshire? Because you know they might be struggling in their caring role. This applies to all of us. Life is so busy, and the thought that we're supporting people out in our communities yet not helping ourselves, to me there's something really important about making sure that we're all accessing support if indeed we do need it, because when it comes to your own family, it is a different kettle of fish to the people that we help as well. But if you can spread the word, and if you want me to attend any other meetings through your links and networks, more than happy to. But thank you very much, Ruth, for the opportunity, and lovely to see you all.
Thank you, Laura, much appreciated, and we'll look forward to receiving those slides. Thank you again for your time.
See you later, take care, bye.
Right, I've just stopped the recording.